ئەم کاتتان باش پزیشک و قوتابیە بەڕێزەکانی پزیشکی هەروەکو باسمان کرد لە بەشی دووەمی وانەی ئۆنلاینی ECG ئێمە لەگەڵتانین دووبارە دکتۆر عەلی شێخانی لەگەڵمانە و بەردەوامە بێ لە تاوکردنی ئەو وانەیە کە هەفتەی پێشوو بە شێوەیەکی فیۆری باس کرا. بەخێر بێ دکتۆر عەلی.
زۆر سپاس دکتۆرە.
زۆر خۆشحاڵین کە دووبارە ئێمە لەگەڵمانی دکتۆر عەلی سکرینەکە لای تۆیە و خۆشحاڵە بین ئەگەر دەست پێ بکەیت.
باشە بەسەرچاو.
دکتۆر عەلی نازانم سکرینەکەتان شێر نەبووە، ئەتوانیت بچێت بکەیتەوە؟
یەک دەقە دکتۆرە ئێستا. ئێستا تەواو؟
ئێستا تەواوە.
Okay, good evening, everybody. I hope you will be great. In the last week, I discussed the first part of my lecture, which was about the abnormalities of the rhythm and rate. Today, I'm going to discuss about the next part of my lecture, which is about the remaining part of the ECG. So the step 2 in ECG interpretation is to assess the QRS axis and morphology. The normal axis of the heart is between -30 and +90. And when there is left axis deviation, the QRS axis is less than -30, as in this green line. When there is right axis deviation, the QRS axis greater than +90 in yellow color. And when there is extreme axis deviation, the QRS axis between 90 and 180 in this yellow line. The most efficient way to estimate the axis is to look lead 1 and IVF. I put an example for each axis deviation. So if you have normal axis, you have to look for lead 1 if it is positive, and also IVF if it is positive again. It means there is normal axis. The direction of electricity is toward lead 2, or between 0 to 90, sorry. So this is the normal axis of the heart. When lead 1 and IVF, both of them are positive. If lead 1 is positive and IVF is negative, it means there is left axis deviation. The direction of electricity is between 0 to minus 90. If lead 1 is negative and IVF is positive, it means there's right axis deviation. The direction of electricity is between plus 90 to 180. And when both of them are negative, lead 1 and IVF, it means there is extreme access. Usually occurs when there is abnormal activation of the ventricle, occurs in VT or in patient with pacemaker. We have different causes of right axis deviation or left axis deviation. I'm not going to waste too much time by the causes. You can take the lecture later on. And then we have to look for the QRS morphology. We have several morphological changes of the QRS. First, if you have pathological Q wave, usually indicate prior myocardial infarction or advanced cardiomyopathy. I put an example. This is a 65-year-old diabetic man presented with chest pain of about 4 hours. Looking to this ECG, there is ST segment elevation in the inferior leads, and there is established Q wave. The Q wave is the first negative deflection. These are Q wave. It is first negative deflection without any positive wave. So any first negative deflection regarded as a Q wave, and usually the Q wave is pathological if it is more than 2 millimeter in width and more than 1 millimeter in, more than 2 millimeter in depth and more than 1 millimeter in depth. And then we have another morphological abnormality is right ventricular hypertrophy or left ventricular hypertrophy. Starting first by left ventricular hypertrophy, usually occur when there is fixed or dynamic obstruction to the LV, as in aortic stenosis, hypertension, or hypertrophic cardiomyopathy. This results in increased R wave amplitude in the left-sided ECG leads, I mean in lead 1, IVL, V4, V6, and increased S wave depth in right-sided leads, like lead 3, IVR, V1 to V3. Of course, we have several ways for the diagnosing of the left ventricular hypertrophy, but the simplest one is the Sokolow Lyon criteria, the simplest one for the students. Usually is the summation of the depth in V1 S wave, depth in V1 plus tallest R wave height in V5, V6, if it is more than 35 millimeter, indicate there is voltage criteria of left ventricular hypertrophy. And voltage criteria should be associated with non-voltage criteria so as to consider diagnostic for left ventricular hypertrophy. The non-voltage criteria includes T wave and ST depression abnormalities. So sometimes you may face a patient with normal person have voltage criteria of left ventricular hypertrophy, especially in thin patient, but to be considered as pathological should be associated with non-voltage criteria of the LVH. It means T wave inversion and in the left-sided leads and ST segment depression. In this ECG, if you calculate the S in V1 and R in V6, usually it is more than 35 millimeter, more than 7 large squares. This is a voltage criteria and associated with non-voltage criteria, which is T inversion and ST depression. This is a strain pattern, what we call. So this ECG is typical of left ventricular hypertrophy. Right ventricular hypertrophy, again, it has some criteria. Usually there is right axis deviation. Right axis deviation, as I mentioned before, that in lead one, there is negative and IVF is positive. So this is right axis deviation. And we have dominant R wave in V1 more than 7 millimeter tall or R to S ratio more than 1. If you look to V1, there is tall R wave more than 7 millimeter. And of course, we have different causes of right axis deviation, starting from pulmonary hypertension, or sometimes could be secondary to left-sided disease like mitral stenosis complicated by pulmonary hypertension or pulmonary embolism, chronic lung disease, cardiopulmonal, congenital heart disease, or arrhythmogenic right ventricular cardiomyopathy. Another morphological abnormalities of the QRS when we have left bundle branch or right bundle branch block. And normally, the septum is activated from left to right, producing small Q wave in the lateral leads. In normal heart, the direction of the electricity is from left to right side. So it produces a small Q wave in the lateral leads, I mean in lead 1 and V5 V6. But whenever there is left bundle branch block, the normal direction of septal depolarization is reversed. It becomes right to left. As in this figure, the septal depolarization is from right to left. And when it completed the right side, then it goes to the left side. So it takes a longer time to depolarize the ventricle. That's why there is widening of the QRS complex, because it takes a longer time to depolarize the whole ventricle. And we have several causes of left bundle branch block, aortic stenosis, ischemic heart disease, hypertension, dilated cardiomyopathy, or anterior myocardial infarction. ECG diagnostic criteria: when you have QRS duration more than 120 milliseconds, and you have dominant S wave in V1, as in this ECG, dominant S in V1, and broad monophasic R wave in lateral leads, lead 1, IVL, V5, V6. This is lead 1, IVL, V5, V6 should be positive R wave deflection. And usually, as I told you, there is loss of the septal Q waves because the direction of electricity is from right to left. That's why there is no any Q wave in the lateral leads. Normally, there is small Q wave in the lateral leads because the direction of electricity and direction of septal depolarization normally from left to right. But whenever there is left bundle branch block, the direction is reversed, become right to left. That's why there is loss of septal Q wave. And the morphology of the R wave, sometimes M-shaped or could be notched, sometimes monophasic or RS complexes. So it is not necessary only to be M-shaped. Every morphology is possible. In right bundle branch block, again, the same idea, but there is block in the right bundle and the depolarization is from left to right. That's why it takes a longer time to depolarize the whole ventricle. The ECG criteria, again, there is broad QRS complex more than 120 millisecond or more than 3 small square, and there is RSR pattern in V1, V2, V3. and wide slurred S shape in lateral leads. Is exactly opposite to the left bundle branch block. And if we discuss about the causes, usually it occurs in right ventricular hypertrophy or cor pulmonale when there is pulmonary embolus or ischemic heart disease, rheumatic heart disease, myocarditis or cardiomyopathy, degenerative disease of the conduction system, or congenital heart disease. This ECG was taken from a 25-year-old male patient who had history of acute myocardial infarction before 1 week and underwent primary PCI of the left anterior descending artery. Looking to this ECG, there is positive R in V1, and there is widening of the QRS complex, more than 3 small squares. And there is deep S in V2, V3, and also in V5, V6. V5, V6. So it is fulfill the criteria of right bundle branch block as a secondary to myocardial infarction. And it is a common cause of right bundle branch block. We have a term which we call intraventricular conduction delay. So what is the difference between intraventricular conduction delay and bundle branch blocks? Sometimes we may have an ECG with widening of the QRS complex, but it is neither right bundle branch nor left bundle branch block. So what could be this ECG? Sometimes there is non-specific intraventricular conduction delay. Looking to this ECG, if you look to the V1, the V1 is negative, so it is not right bundle branch block. And if you look to the V6 is also negative, so it is not left bundle branch block. So it is neither left bundle branch nor right bundle branch block. So it is a specific term, what we call intraventricular conduction delay. There is only delaying, but without blocking of the bundles. Usually occur in advanced cardiomyopathy and there is fibrosis. Another morphological criteria, looking for the voltage of the QRS. We have low voltage QRS, the definition, when the amplitude of all the QRS complexes in the limb lead is less than 5 millimeter, or the amplitude of the QRS complex in the precordial lead is less than 10 millimeter. The causes could be fluid like pericardial effusion, pleural effusion, or could be fat, obesity, or sometimes air, emphysema, pneumothorax, infiltrative cause, myxedema, or restrictive cardiomyopathy, constrictive pericarditis, and so on. This ECG is an example of low voltage criteria. If you look to limb leads, the amplitude is less than 5 millimeter, and there is sinus tachycardia. This ECG was taken from a patient with massive pericardial effusion and cardiac tamponade. So there is a large amount of the fluid that makes the amplitude of the QRS is small. Another morphological features of the QRS, looking for the delta wave. This ECG is taken from 38-year-old female presented with palpitation. There is a positive slurred upstroke deflection before QRS and short PR interval. So this is a typical ECG. Features of WPW syndrome or pre-excitation. So I finished the second part of the ECG, which is the abnormalities of the QRS complex and the axis. The third part, we have to assess ST segment, T wave, and QT interval. This is an important part of the ECG. Frequently, we may face an ECG with ST segment elevation, but we have several causes of ST segment elevation. Not every ST segment elevation is myocardial infarction. For example, we have a long list of differential diagnoses, starting from STEMI, pericarditis, left bundle branch block, left ventricular hypertrophy, or could be normal variant, which we call early repolarization syndrome, LV aneurysm, vasospasm, or Brugada syndrome. And of course, we have another causes. I put some examples for each of them so as to make it easy. This ECG is from 25-year-old man with no cardiac risk factor apart from smoking. Is brought to the emergency department by his brother, and he has an acute onset substernal chest pressure. If you look to this ECG, there is ST segment elevation, but the pattern of elevation is diffuse. It's not localized, involving anterior leads and inferior lead. And there's PR segment depression with reciprocal PR segment elevation in IVR. And the pattern of ST segment is concave shaped. So this ECG is typical of pericarditis. How to recognize pericarditis? When there is widespread concave ST elevation and PR segment depression throughout most of the leads, and there is reciprocal PR depression and PR elevation in lead IVR. PR elevation in IVR and PR depression in all other leads. And there is no reciprocal ST segment depression in other leads. Later on, I will discuss what is reciprocal change. So this is not myocardial infarction, although the patient has chest pain and ST segment elevation, but the pattern of this ST segment elevation is not of myocardial infarction. It is of pericarditis. This is PR segment depression, and this is PR segment elevation in IVR. This is another example. This patient had a 65-year-old diabetic presented with chest pain. This ECG also, there is ST segment elevation, but this ST segment elevation is different from the previous one. It is localized, just involving the inferior leads, and there is reciprocal changes. What's reciprocal change? Reciprocal change means there is a mirror image of ST segment elevation, which is ST segment depression in the opposite leads. For example, in the lateral leads, there is ST segment depression, and in the inferior lead, there is ST segment elevation. So this ECG is typical of myocardial infarction, ST segment myocardial infarction. Also there is Q wave, as I mentioned before. There is Q wave before ST segment elevation. This is another example, 50-year-old male patient without any risk factor, presented with chest pain. Her parents bring him to the nearby emergency department when an ECG is obtained. This ECG, again, there is ST segment elevation, but in the anterior leads, involving V1 to viscous. So this is acute anterior myocardial infarction. This ECG also, there is ST segment elevation, and it It is taken from a 70-year-old diabetic patient presented with SOP of about 1 month. If you look to this ECG, there is Q wave and persistent ST segment elevation and small T wave inversion. So this ECG, from the history, it goes with LV aneurysm because the duration is more than 2 weeks, and still there is persistent ST segment elevation, and there is Q wave, established Q wave. So the ECG features of LV aneurysm, there is ST segment elevation seen more than 2 weeks following an acute myocardial infarction, and most commonly seen in precordial leads. Usually associated with well-formed Q wave, and T waves have relatively small amplitude in comparison to the QRS complex, and factors favoring left ventricular aneurysm rather than acute myocardial infarction. Of course, if you have previous ECG and absence of dynamic ST segment changes, absence of reciprocal change, there is no reciprocal change in this ECG, and well-formed Q wave. Another cause of ST segment elevation, a 40-year-old male with attacks of dizziness and one syncopal attack during his childhood. Looking to this ECG, there is localized ST segment elevation in V1, V2, and it is coved-shaped. The shape of this ST segment is different from that we have seen previously. So it is a typical ECG finding of Brugada syndrome, presented with ST segment elevation in V1, V2, V3. It could be coved-shaped or saddleback appearance, and it is restricted to V1, V2, V3. This is a 40-year-old male patient with mixed aortic valve disease and VSD, recently diagnosed as infective endocarditis, having severe chest pain. This ECG is left bundle branch block because lead 1 is positive, this is positive and M-shaped, and there is widening of the QRS complex. So this, if the patient has chest pain with left bundle branch block, usually we have to think about myocardial infarction, but sometimes we may face some difficulties in diagnosis, especially if the patient has pre-existing left bundle branch block. It is difficult to know whether this left bundle branch block is new or old. So how we solve this problem? We have a criteria which we call Scarboza criteria. The original 3 criteria used to diagnose infarction in patient with left bundle branch block are usually in patient with left bundle branch block, there is discordant ST segment and T waves. This is in usual patient in left bundle branch block without myocardial infarction. I mean, when the QRS is positive, the ST segment and T wave is negative. And when it is negative, the ST segment is positive. But when there is an acute insult, for example, if there is myocardial infarction, these changes, the new changes will occur. According to Scarboza criteria, if you have a concordant ST segment elevation more than 1 millimeter in leads with positive QRS complex, like in this lead, if it is positive and ST segment elevation more than 1 millimeter is very significant. And if you have concordant ST depression more than 1 millimeter in V1, V2, V3, also it is very significant, ST segment depression in V1, V2, V3. And if you have discordant ST elevation more than 5 millimeter, this is a Scarboza criteria. A total score of more than 3 is reported to have specificity of 90% for diagnosis of myocardial infarction. This is another cause of ST segment elevation. 25-year-old man presented with atypical chest pain is otherwise healthy with no significant finding of examination. This ECG is taken as part of workup. There is ST segment elevation again, but the pattern of ST segment elevation is different from others. Usually this is a early repolarization syndrome. It is a benign early repolarization syndrome. The ECG criteria when you have widespread concave ST elevation, most prominent in V2 to V5. This is really this widespread ST elevation and notching or slurring at the J point. This is a J point. There is notching at the J point, what we call fishhook appearance. And of course, there is no reciprocal changes in contrast to myocardial infarction. So this is a benign condition, does not need any intervention or any specific therapy. I finished the ST segment elevation. Let me discuss about the ST segment depression. Of course, the ST segment depression has a lot of differential diagnosis, starting from myocardial infarction or ischemia, tachycardia and pre-excitation, left bundle branch, right bundle branch, intraventricular conduction delay, RVH, LVH, sometimes drugs like digoxin or electrolyte disturbance like hypokalemia. This is a 65-year-old diabetic man with 25-year history, smoking history, develops retrosternal chest pain. The ECG, there is diffuse ST depression from V1 to V6. So if you have this ECG with, and the patient has typical ischemic chest pain and has multiple risk factor like smoking and diabetic, so there is high likelihood that the patient has acute cardiac insult, possibly non-STEMI or unstable angina. We have additional causes of ST segment depression, especially in patients with SVT, IVNRT. Sometimes there is upsloping of the ST segment during tachycardia. And in patients with WPW syndrome, as I mentioned, there is repolarization abnormality and what we call pseudo-infarction pattern. And in patient with left bundle branch block, there is ST segment depression. And in patient with LVH, again, so not every ST segment depression is myocardial infarction. We have several causes. And examine the T wave. The T wave, we have two abnormalities, either T inversion or peaked T wave. Let me start first with causes of T inversion. We have several causes like ischemia or tachycardia, pre-excitation, left bundle branch, exactly similar to the causes of ST segment depression with few changes. For example, raised intracranial pressure, pericarditis, or hypothyroidism. This ECG is taken from 60-year-old man presented with several episodes of retrosternal chest pain. Again, there is T inversion in the anterior leads from V1 to V5. If you have a patient with chest pain and with this ECG, there is high possibility of a cardiac insult. So you have to put the cardiac origin of chest pain in the top of the differential diagnosis. You are asked by neurologists to see a 60-year-old female patient with history of hypertension presenting with left-sided weakness. The brain CT revealed large ischemic stroke. Neurologist worried about this ECG and wanted to take your opinion. Again, this ECG, there is T inversion, but the presentation is different. The patient has neurological insult. So this is not related to the cardiac origin. It is probably cerebral T wave inversion secondary to hormonal changes, and it is commonly found in patients with large ischemic stroke or hemorrhagic stroke. And this ECG is taken from a patient with apical hypertrophic cardiomyopathy. Again, there is deep T inversion in the precordial leads. So T inversion has different differential diagnosis. The peak T wave, the two most important causes of peak T wave, we have myocardial infarction and hyperkalemia. This ECG is taken from a patient with myocardial infarction. There is hyperacute T wave usually occur in the first hours of the myocardial infarction, and later on it will progress to ST elevation myocardial infarction. And this is this ECG is taken from a patient with hyperkalemia. Again, there is peak T wave. The last part of the ECG is to measure the QT interval. The QT interval is the interval between the beginning of the Q to the end of the T wave. And usually it represents the time taken for ventricular depolarization and repolarization. The QT interval is inversely proportional to the heart rate. The QT interval shortens at faster heart rate and lengthens at slower heart rate. Normal QT interval. QT is prolonged if more than 440 milliseconds in men or more than 460 milliseconds in women, and if it is less than 350 milliseconds, regarded as short QT. And of course, we have several causes of prolonged QT interval, starting from electrolyte disturbance, hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, myocardial ischemia, raised intracranial pressure, congenital long QT syndrome, and sometimes medications, which is a common cause of long QT. And because the QT changes with the heart rate, so it needs to be corrected. We have several formulas for correction. The simplest one is Bassett formula. 77-year-old female patient with history of thyroidectomy 10 years ago presented with this ECG. Usually, in this ECG, there is long QT syndrome. You know, during thyroidectomy, sometimes the parathyroid hormone will be removed, so the patient will develop hypocalcemia. And in the ECG, there is long QT secondary to hypocalcemia. This is another example of long QT, but it is due to raised intracranial pressure. This ECG taken from a patient with subarachnoid hemorrhage. There is ST inversion, as I mentioned before, and there is long QT. This is another example of long QT. There is flat T and long QTs. This patient receiving large dose of diuretic and develops hypokalemia, and then with secondary long QT and develop torsadipoviti as a cause of, as a secondary to hypokalemia. And this is the last slide. This ECG is taken from 90-year-old male patient presented with recurrent syncopal attack and one attack of resuscitated cardiac arrest. He has strong family history of sudden cardiac death. If you look to the QT interval, is very short QT. So this is a short QT syndrome. This is a very rare condition, but it is associated with sudden cardiac death and it is familial. And thank you.
Thank you, Dr.
I
Ali.
finished my lecture. If you have any question, I'm ready to answer your questions.
دست خوش دکتوره.
Thank you, Dr. Ali, for the nice presentation. From the participants, if you have any question, you can raise your hand and you can give your mic. I think till now, Dr. Ali, just have a question from the chat. How we could differentiate between pericarditis and benign early repolarization?
Okay. Sometimes there is difficult to differentiate between them, but in pericarditis, as I mentioned, there is PR segment depression in all the leads and PR segment elevation in IVR. These changes is not present in benign early repolarization. And also the ST segment elevation, the ST segment elevation in comparison to the R wave in pericarditis is usually more than 25%, in benign early repolarization is more than 25% of the QRS length, and in pericarditis is less than 25% of the QRS length. And in pericarditis, again, there will be evolution in the ECG. Sometimes initially there is ST segment elevation and later on it becomes T inversion. But in early repolarization, there is no evolution in the ECG. And of course, the symptom is also important. Usually the patient, we have typical features of pericarditis, that the chest pain aggravated by lying down and relieved by leaning forward. Sometimes the patient may have history of fever few days before. So that is the differentiation, of course. And cardiac enzyme sometimes will help us.
Thank you, Dr. Ali, for the clarification. We have another question. Do we need to send for cardiac enzyme if ECG show SBT with the ST depression?
No. Usually the SVT frequently associated with depression. Why? Because of two reasons. First, the T wave of the P wave, usually in normal in heart rate, it located within the QRS complex, is not appear on the normal ECG. But when the heart rate is increased, this T wave goes after the QRS and it looks like ST depression. That is the reason. The second point, during tachycardia, there is imbalance between oxygen supply and demand sometimes. It also causes ST segment depression. So it is not necessary to send for the cardiac enzyme.
Great. I hope for this one answer, the answers are clear for you. Thanks again, Dr. Ali. I think this is all the question that I have. If dear students, you don't have any other question, we're gonna close today's live, and this process is gonna be continued with some practical session. Dr. Ali, do you have any extra points or anything else that you need to share with our doctors and students?
Thanks, Dr.
Thank you to everyone. Enjoy your weekend.
دستان خوش. Thanks دکتر علی. دست خوش دکتر جان.
دکتر علی دستکند خوش بیا خوا.
Okay.